Welcome back. Oh. Welcome back. Comment allez-vous? Bonjour. J'ai mangé the baguette. Bellissimo. Robin, don't break it, the pasta.
Oh, no, no pasta breaking.
I was actually hoping that Sharmizi can unmute herself and say a few words.
Yes.
It's been a while since I've seen Sharmizi.
Woo!
I just miss you, Prof. Raz. We're doing good. It's good to be back in the VMR. I have missed this community so much. And, you know, I cannot wait for some RR magic today.
I think I'm out of magic. We're so happy to have you back. And I don't think, Robbie, do we have a pre-established case presenter today? We don't. I want to welcome someone to present a case that's fascinating, but no pressure. One that takes us through a roller coaster of a journey. Yeah, I remember someone, I don't know, someone's probably not on this call, but whenever I would discuss a case where I just felt like I didn't do a great job, someone would see me pacing around in the kitchen and he would say, someone present Reza an E. coli urinary tract infection quick to get him calm. So my friends, I am hoping one of you can volunteer to present a case. It does not have to be a roller coaster of a case. Any case will suffice. And while we're looking for someone, let me give the mic to the mathematician to add his math.
Hello, everyone. I'm not going to say good morning because I know there's a dear friend who's joining us for the first time. In fact, I know that they're joining us from South Korea based on their email that they sent to us yesterday. Kim, do you want to unmute yourself and say hello?
Oh, hello. I'm very surprised that I have some opportunity to greeting you guys. And I'm from South Korea, and I'm, can I introduce myself before that?
Please.
Okay, thank you. I'm from South Korea, and now I'm public health doctor in the rural area of the South Korea. And these days, I'm very busy for the coronavirus vaccination. So I really wish to learn from you guys, and thank you. This is nighttime in here, Korea. It is about 1 a.m. So I'm little drowsy. Also, hope you guys to care about myself. Thank you.
At 1 a.m., I'm in the middle of REM sleep, my friend. Can I ask you one question?
Oh, sure.
How do you say good morning in South Korean?
We say good morning. It's pronounced real difficult. Okay. We say 좋은 아침입니다.
Say it one more time.
좋은 아침입니다. 좋은 아침입니다.
Okay, you know what? I need to find you for a private session because I that's very hard for me to do. Thank you.
Yeah, thank you.
I appreciate it. Maybe you can find, maybe I can email you or find some time to connect one-on-one, but thank you so much for joining us.
Okay, thank you.
That's all I got, folks. Who has a case? Going once. Here's my yogurt. Going twice. I guess that's it. Oh, poor Kim. The first time he joins us, no case. Oh, man. How sad. 1 a.m. in South Korea. Look at that dedication, yo. 1 a.m. Anyone? Vale, that sounds wonderful.
Yeah, I have the file, so if anyone wants to present and they don't have a case, I can send them to you.
Yeah.
You
Maybe
just,
for the sake of time, do you are you doing anything else today, or do you want to present it yourself?
I'm scribing, so
Oh,
yeah.
okay. All right. It looks like Anne-Marie has a case.
Oh, great.
There's nothing that's simple, my friend. Trust me, Reza and I just discussed a case at a conference, and even though it was simple, it was not simple at all. So that would be awesome.
Well, this is going to be very thrown together, but I can go ahead and make it happen.
That would be awesome. Thank you.
Okay, I will give the chief complaint. This is a 35-year-old female presenting with fever, pharyngitis, and body aches. I'll leave it there and then give some more HPI data.
Alrighty, I'll kick us off, and I will just say pharyngitis is one of those fascinating itises, i.e. inflammation, that actually spans the entire I-made mnemonic. There are many infectious causes of pharyngitis, and believe it or not, there are many autoimmune causes, malignant causes, drug-induced causes, and endocrinopathies. And I think the focus initially is almost always on infectious causes until proven otherwise. So we'll have to talk about the whole I-made mnemonic, but the focus initially is on infections. And I'll pass the mic to Reza to see what infections cross his mind or anything else that he might be thinking of.
I love that approach, Robbie, and I agree 100%. And this is a young patient. So of course, this patient has inflammation, and the localizing site, as Robbie mentioned, is the pharynx. And what we should prioritize is the infection category. And I think a key question is going to be actually looking in this patient's mouth and seeing if it's suppurative pharyngitis or not, and also making sure that their airway is patent and we're not dealing with, for example, a peritonsillar abscess. But Robbie, the infections that I think of right off the bat includes group A strep. And here I wish Dr. Centaur was here. We could apply his criteria, which can affect the post-test probability of strep pharyngitis. But in a young person, even in an old person, you can think about sexually transmitted infections that can involve the pharynx, from EBV, CMV, syphilis, gonorrhea. All of those, I think, chlamydia, all of those are at play. And I think at branch point 1, I think this is one of those complaints where honestly, I would go from the complaint right to the physical exam and see if I'm dealing with, suppurative pharyngitis or an emerging cause of pharyngitis, or if there's some kind of local complication. And I don't want to sort of share that schema yet until we get more data, because I just want to invest that cognitive energy in the right way. So for me at gram point 0, is this viral pharyngitis more likely, or is this, and virus, I'm not saying CMV, EBV, but just like run-of-the-mill adeno, rhino, any of those viruses, or is this strep pharyngitis, and does this patient need antibiotic? And I use Centaur's criteria, honestly, to help guide me in that way, but just broaden it a little bit to include the sexually transmitted infections too in this age group.
Awesome. So in regards to past history, she had a history of Graves' disease and had stopped treatment 8 months ago due to being in remission at that time. Her thyroid levels had been stable, but then she saw her primary care physician about a month ago with some tremors and weight loss, and labs showed a suppressed TSH at that time. She had not restarted treatment though. She had also been following in the hematology clinic for some mild neutropenia, and had started B12 supplementation at that time, and was going to follow up with consideration of a bone marrow biopsy if it did not resolve. So as far as the history, she presented with 3 days of the fever, diffuse body aches, throat pain, and headache. Described the headache as diffuse and bilateral, with a little bit of neck pain, but no like nuchal rigidity, photophobia, phonophobia, or anything like that. Temperatures as high as 102 degrees Fahrenheit at home came in after discovered the heart rate was 159. Felt like the symptoms started suddenly and was unable to eat for 2 days due to the pain in her throat. She also described feeling tremulous and diaphoretic. Started having some hyperdefecation with 4 soft but formed bowel movements without blood in them about a day ago. No nausea or vomiting, no dysuria, had some scant vaginal discharge, had recently tested positive for BV at urgent care. No rashes, no other eye abnormalities or proptosis. And then also reported that she, as well as a pharyngitis, felt like a little pain above her thyroid as well. As far as exposures, no tick bites or mosquito bites or abnormal outdoor exposures, no recent travel, no pets at home. Sexually active with 1 long-term monogamous partner, denied oral sex, no alcohol, tobacco, or drug use, no over-the-counter medication use. And then last menstrual cycle was a week ago. Also had a COVID exposure 2 weeks ago, but has tested positive several times tested negative several times since then. Last test was on the day of symptom onset, and is also fully vaccinated against COVID-19. Has some exposures to children, but denies any one with like respiratory symptoms or the same symptoms. And I will leave it there.
Wow, I think there's so much to digest here. And maybe I'll just speak a little bit and then pass the mic to you, Robbie, to just take off wherever you want to go, okay? But I think the most important part of this case is the background data that Anne-Marie shared with us. So this patient has been diagnosed with Graves' disease. It'll be very important to know how this diagnosis was made. Did they send the relevant antibody showing thyroid stimulation that reached the diagnosis? Because with Graves' disease, you usually have enlargement of the thyroid gland because you have increased vascularity. These patients often have a bruit, or they may have a bruit, which heightens the possibility. They're thyrotoxic from hyperthyroidism. So high thyroid levels, low suppressed TSH. And again, it's like diffusely enlarged. And if you did an ultrasound, you would see this increase in vascularity. The treatment for it is, one, you can control some of the increase in the sympathetic tone with a beta blocker, but then there's medications to decrease the conversion of the T4 to the active T3. And some of the options include methimazole and propylthiouracil, though you have to take the patient's age and premenopausal status into consideration when you're prescribing these. But these drugs don't treat the underlying cause, which is an immune-mediated enlargement of the thyroid gland. So when you diagnose Graves, you can actually cure it. So once you reach the diagnosis, you wonder whether there was a plan to go for radioablation of the thyroid gland to cure this patient's Graves, and then follow her thyroid function test to see if she needs replacement. But this patient, I'm not sure what specific thyroid medication she's been on, because then we can see complications of those. And having agranulocytosis is different than neutropenia, because granulocytes are any white blood cell that have granules. These include neutrophils, eosinophils, and basophils. In this patient, I would be interested to see what the diff is, because a lot of these anti-thyroid drugs are notorious for causing sort of bone marrow suppression. And some of them can actually cause aplastic anemia. But why is that? Why is all this relevant? For two reasons. One is if you're neutropenic, you're at risk of bacterial infections. We don't know why she's neutropenic. Again, if the patient was on antithyroid, we would stop that and evaluate. But I have a low threshold to refer a patient for bone marrow biopsy who's neutropenic. But this increases the risk of bacterial, not viral infections. Viruses, you have lymphocytes, and there's no reason for us to think this patient's lymphocyte count is low. So all of a sudden, Robbie, for me, it's like prioritize one, a bacterial infection, whether it's strep, Fusobacterium, and then her sexual history also prioritizes the sexually transmitted infections, gonorrhea, chlamydia, syphilis. And I think with the Graves' disease, where she's now stopped treatment, because that treatment is just putting a Band-Aid and controlling the sequela of excess thyroid levels. You take off the treatment, you haven't solved the immune-mediated enlargement and increased synthesis of the thyroid gland. So you're gonna have thyrotoxicosis, you're gonna have fever, weight loss, hyperdefecation, and maybe the infection triggered another flare of this patient's thyrotoxicosis. Mike, to you, my friend. And I can't wait to hear Tiago's, at the end of this, I can't wait to hear Tiago's reflection. And every time he speaks, he adds something, you know, like with adrenal insufficiency and hyponatremia, like he's really teaching us. So I can't wait to hear him reflect on this.
I couldn't agree more. We've had now 3 and probably 4 VMR endocrine cases in a row this week. It's such a treat. And I actually don't have anything to add, but I want, like, you added so much rich detail to our illness script for Graves' disease and where this could be. And I just want to anchor you in the world that you probably would be in real life in pharyngitis. And here's how pharyngitis plays out in the ER all the time. Pharyngitis without systemic features is the most common presentation. So let's be real. This case is very different immediately. Why? When somebody comes in right there with pharyngitis, they usually walk in and they say, it hurts here, and then that's the end of the story. That's it. So pharyngitis in that situation is either one of two things. They have a virus, and there are some morbid viruses to think about, such as COVID, and then the mononucleosis viruses like EBV, CMV, and HIV, or they have group A strep. End of story. This is not that. So don't, make sure you represent your problem correctly. This is pharyngitis with systemic symptoms. No one with the garden variety pharyngitis, of which maybe 1 or 2 people will come here today, will have prominent systemic symptoms. So just because the chief complaint happens to be pharyngitis may mislead you into you thinking that this is a common garden variety pharyngitis. But no, that's not how pharyngitis common variety presents. That is pharyngitis without systemic features. Here, a whole new universe. Pharyngitis with systemic features, apply what Reza is saying. But I want you to know, most commonly, there are no systemic features. How are you going to remember this? If I come in and I tell you I have a cough, and I just have a cough and I have no shortness of breath, nothing, you are much less worried about me than if I tell you I have cough with dyspnea. The landscape is very different. Somebody is coughing and they're huffing and puffing is very different than somebody coughing and being just fine. This is a very, very unusual presentation of pharyngitis, which will take us down to less common diagnoses. And the reason is because it has systemic features. All right, Anne-Marie, back to you.
Okay, great discussion. And since this case is thrown together, some of the questions I might not know the answer to, but I will try my best. As far as the medications, was not currently on any medications aside from over-the-counter Tylenol, had been on methimazole in the past, but had stopped it 8 months prior. And then as far as vital signs, the temperature was originally 39.3 degrees Celsius. But had later defervesced and was 37.8 degrees. With the fever, the heart rate was 130, but after the fever resolved in IV fluids, the heart rate improved to 94. The respiratory rate was around 18. The blood pressure was normal, with systolics around 120s, diastolics around 70s to 80s. And the oxygen saturation was around 96% on ambient air. As far as the exam, it was examined after the fever had resolved. So generally appeared comfortable and no acute distress. As far as the eyes, there were normal extraocular movement, normal conjunctiva, and then reactive to light bilaterally and no proptosis seen. As far as ENT, there were enlarged nasal turbinates with a bluish hue. And there, as far as the throat, there was erythema with some small exudates on the tonsils, but normal like airway was seen and no stridor, no cervical lymphadenopathy was felt, and there was normal range of motion of the throat, no signs of odontogenic infection. As far as cardiovascular, kind of borderline tachycardic, but regular rate with no murmurs. The lungs were clear with symmetric air movement, no wheezes. The abdominal exam was normal. There were no rashes seen, and then no like synovitis on the joint exams. And then the neuro exam was normal aside from a fine tremor of the hands. And then, yeah, everything else is normal. Oh, there was a little tenderness over the thyroid as well. No bruit on the thyroid exam. Do you want to discuss here, or I can try to pull up the labs as well?
I think this is a super helpful place to discuss, and I want to commend you for putting this case together. There's so much detail, and Emery, the fact that you can actually like string this together in a cohesive story with minus 10 minutes of notice is unbelievable. Thank you. May I ask just one clarifying question? How long would she stop the methimazole? I thought you mentioned months, but I wasn't sure.
8 months ago.
Okay, it's amazing how that detail, if accurate, if the patient may accidentally be taking or substituting another pill for it. So if we believe that if we are confident that there's no methimazole in her body for 8 months, the most morbid diagnosis of methimazole-induced agranulocytosis would become much less likely. But I think the progress that we made on the exam is to worry a lot about this patient. And I think that a heart rate and a fever like that really, really makes us worry about inflammation. And it's interesting because you ask yourself, is there anything that skews the base rate of inflammation here? And the base rate, just to be clear, is that inflammation, you start with the infection, you move to malignancy, autoimmune, drug, and endocrinopathy. And I'll try to make the argument that nothing skews the base rate. Nothing will overcome what's happened to the last 100 people with inflammation. But there's one very unique finding here. So when people are inflamed, they have, and pay attention to the key word here. The key word, if I could bold it in writing, would be compensatory. When people are inflamed, they have a compensatory sympathomimetic response. So what happens? Heart rate goes up as a compensation to the blood pressure having the propensity to go down. Okay? But that sympathetic response is compensatory. And just like we talk with acid-base abnormalities, compensatory response will never be in excess of the driver. You can never have compensatory respiratory alkalosis more than the metabolic process driving it. So you can never have enough compensatory sympathetic increase when you're sick and about to die, more than the insult itself. That's why you need to come and see a physician. And if you're really sick, you need us to add the sympathetic mechanism to your body so you live. Norepinephrine, dopamine, epinephrine, steroids. But this patient, despite being inflamed, has evidence that her sympathetic mechanism is pathologically activated more than what compensation would be. How do we know that? What are the markers of sympathetic toxicity? The markers of sympathetic toxicity that are unique to too much sympathetic tone is the presence of a tremor and spontaneous hypokalemia. Those are the two things that are markers of too much sympathetic tone. Sinus tachycardia, soft blood pressures, diaphoresis, all those can occur as a compensatory. But if your sympathetic system is so much that you're shaking from it, it's not in response to a physiologic syndrome. So here, there is the base rate of inflammation, which prioritizes infection, but then we have to enter another world. And that other world is the presence of sympathetic toxicity as evidenced by the presence of a tremor in this patient. And that world takes us here. Is she having cocaine, meth, caffeine on board? Is she withdrawing from alcohol? Is she have benzo or baclofen withdrawal? Is she in pain from this, or is she experiencing excessive anxiety? Or, as the spotlight has already been on this condition, is she having thyroid issues again? There's so many things here, but I think as we talked about earlier, and as Reza alluded to, you have to worry about infectious causes. But the one inflammatory disorder that overlaps with sympathetic excess is the thyroid here. So this exam is very concerning for thyroid toxicosis. There are a lot of other things I actually didn't that didn't capture my attention. So I'll pass the mic to Reza to see what he can clean off my my focus on this this tremor, but it really stands out to me.
I have nothing to clean off. I will say, you remember, Robbie, I don't know where we were discussing a case where the patient had a tremor and we glossed over it and it ended up being thyroid toxicosis. But this is what I'll say. There's two things that like my mind is trying, like one of the things is obvious, like this patient is likely in thyroid storm. So you can use the Birch-Warchowski calculator. And I actually did that while Anne-Marie was presenting with the degree of tachycardia, the degree of fever, the hyperdefecation, all of that, if you add up, it strongly suggests thyroid storm. Why is that important? Because we know that this patient can decompensate rather quickly with cardiopulmonary decompensation. Another important thing to note is like I would be cautious with quickly reaching for propranolol or beta blocker. Why do I say that? The year was 2014. Yes, 2014.
You got your math right.
And at that point, I had a lot of hair. Like if you guys were wondering how I looked like with hair, I had a full set of hair. But I was in Saipan, in the northern Mariana Islands, in Saipan. There was a special relationship between UCSF and a hospital out there. And this patient came to the hospital with acute hypoxemic respiratory failure, quickly had to be intubated, got imaging that showed bilateral, pulmonary edema. And the question was why? And just like Robbie said, the patient had an increase in what appeared to be sympathetic tone. We sent a TSH, undetectable. The thyroid level was super elevated. And so the patient had thyroid storm and was on a pressor. And I thought, okay, there actually was no endocrinologist. There was no one like Tiago there because it was just an island, 50,000 people, 3 internists, like 1 surgeon, no cath lab. Like you would have to give thrombolytics. So of course I jumped on Up to Date and I said, how can we treat this patient? At first, I mistakenly gave propranolol. The patient was going very fast, was borderline hypotensive. After I said, give propranolol, you know what I said next, Robbie? I said, give some epinephrine. The blood pressure is plummeting. Then we ended up giving this patient Lugol solution or iodine solution by mouth, which oversaturates the thyroid gland. And if you think about Graves' disease, it's the thyroid gland that's producing the thyroid hormone. So mess up the machinery by giving too much iodine. We also blocked the peripheral conversion of T4 to T3 with steroids, with glucocorticoids IV. It blocked the conversion. And we added methimazole. We did these 3 steps and the patient ended up walking out of the ICU, and we labeled it safe from the grave because when we did the thyroid stimulating antibodies, they were positive, and also the tracer uptake demonstrated diffuse uptake consistent with Graves. So I think, Robbie, in this case, like I think we're in the endocrine emergency. I think we need to stop and lower the thyroid levels, but I don't think we've excluded an infection. I'm still very concerned that this infection triggered the thyroid storm. And it takes me back to step 1. Why is this patient neutropenic? If it's been long-standing before the anti-thyroid drugs. And as you guys mentioned, like the timing is just not consistent with that. Then I would worry about like an inherited cause, like a hereditary cause of neutropenia, as opposed to a cause that occurs later in life, like leukemias and stuff like that. So I'm worried, like for me at this aliquot, I'm very interested in the liver chemistry test. I am very interested in decrease in the thyroid study test. And I want to treat thyroid storm, but I also want to treat for likely bacterial pharyngitis, the risk factor being the neutropenia. And then I step back and think, why is this patient neutropenic?
Awesome. So as far as the labs, the WBC was 8.9 with a absolute lymphocyte count of 1.3, and then an absolute neutrophil count of 7. Normal, no EOs, other cell lines on the WBC. Hemoglobin was 13 with a normal MCV, and platelets were 248. As far as the comprehensive metabolic panel, the sodium was 135, potassium was 3.3, chloride was 101, bicarbonate was 28, BUN was 8, creatinine was 0.7, glucose was 95, calcium was normal, albumin was 3.7, total protein was 9.1, and then bilirubin, AST were within the normal range, ALT was 67, and alkaline phosphatase was within the normal range. And then TSH was less than 0.008. T3 total was 1.4. Free T4 was 1.87, with the reference range being the upper limit of normal, 1.76. And then COVID PCR was negative, and urine pregnancy test was negative. ECG showed just sinus tachycardia, but no other changes. And initial chest x-ray was clear.
Robbie, please take it over, my friend.
Oh, alrighty. So I think as Reza predicted, this profile is very consistent with hyperthyroidism or thyrotoxicosis. The T4, the TSH is completely suppressed, and I believe that the T3 is high, though I'm not sure, and the T4 is also high. So we've diagnosed that. And the question, as Reza alluded to, is what is the cause of this? And that's where the thyroid stimulating antibodies and the conversation that he had is very informative. I think that now that the K being low supports the idea that there's too much sympathetic tone on this patient. And the question is, as we remain fixated on understanding the hyperthyroidism, the thyrotoxicosis, excuse me, is there anything else that we need to pick up before we move 1000% towards that training? And the only abnormality otherwise noted is the fact that the patient is lymphopenic. The lymphocytes are relatively low, 1.3, less than 200, at least 2000 in my lab is important. And I will say the following: lymphopenia is common and expected in the face of acute systemic illness, and that's because the steroids, just like they shut down eosinophils, shuts down lymphocytes. So here, there really is no necessary explanation for the lymphopenia in this case, because this patient probably has, unless they have concomitant adrenal insufficiency, a super high cortisol level, and therefore suppressing their lymphocytes. So I think we're, square on the train of thyrotoxicosis, and the question is why? And we have to use the background history with caution, because we don't know that this is Graves' disease. We presume this is Graves' disease. So I don't know if I'd be doing anything differently than saying, hey, this patient's hyperthyroid. Their level of thyrotoxicosis. Well, I should say this: the degree of biochemical thyrotoxicosis is not related to the clinical consequences of it. So just because the patient has only a mildly elevated T4 does not mean that their body is suffering devastating consequences from this, which is why when you look up the clinical criteria for thyroid storm, it mentions end organ damage, but does not require severe thyroid hormone elevations. And I bet that there are nuances to that that hopefully Tiago can enlighten for us at the end. So we're really worried about this patient. I think we're back in Saipan. And so I'll pass the mic to see if Reza has anything else to add, but I think unfortunately, our suspicions have been confirmed.
I just wanted to say, I love the point you made about like the biochemical versus the actual like consequences. Nothing to add. Thank you.
Okay, so as far as kind of other workup, got a urinalysis that showed a specific gravity of 1.03, moderate leukocyte esterase, protein on the UA was recorded as 100 milligrams per deciliter, trace ketones, and then 10 RBCs and 23 WBCs with occasional bacteria. The urine culture later grew mixed flora. HIV test was non-reactive. Respiratory panel was obtained and did not show any positivity for the rather extensive panel. And then chlamydia and gonorrhea of the throat remained negative. And then talked to the endocrine team and was started on methimazole and propranolol. And actually, it was started on ceftriaxone on admission as well due to concern for bacterial pharyngitis, as well as a possible urinary tract infection while things were pending. Blood cultures were cooking. The next morning felt tremendously better. Tachycardia had resolved, was doing really well overall. It did also have a throat swab sent as well. And then I will kind of leave it there to hear some more reflections.
Prof. Thoughts?
Yeah, I think that totally agree with your management, and I too would contact endocrinology in this situation, because I don't know when is the threshold to add agents like iodine, to add steroids IV to decrease the conversion. This patient isn't as sick as my patient, but still I would consider this to be thyroid storm based on the calculator. And I think an HIV test is indicated. Yes, the patient's inflamed. And Kelly,
it was negative.
HIV was negative. Okay,
Yeah.
Great. Yeah, anytime you have lymphopenia, definitely you want to test for that, even if you have concomitant inflammation. And I think Kelly raised a great point regarding the protein gap. And most likely it's polyclonal from underlying inflammation. And Robbie, I don't know, I would love to hear what you think, but I just don't associate like a purulent exudative pharyngitis in my illness script for thyroid disease. So I would continue to treat for bacterial pharyngitis in this patient as a potential trigger. And I think most importantly is making sure the patient follows up for cure of her Graves' disease.
I love it. I think the key question is why. A patient with a chronic disease, presumed Graves' disease causing hyperthyroidism, is now with an acute complication. And, you know, we apply this model to patients all the time when they come in. They have a chronic disease and they're here in the hospital today. Say they have a delirium on top of dementia. They have a COPD exacerbation. They have decompensated heart failure. They have AKI on top of CKD. And we have to answer the question, why does this patient have ATI on top of CTI? Why do they have chronic thyroid disease, but why do they have the acute component? And I imagine, I don't know this landscape very well, but I imagine a large fraction of patients have idiopathic exacerbation, just like a large fraction of patients with COPD do, but a small fraction of patients have a very specific treatable trigger. And I know because I've heard that surgery is a trigger, and gosh, help us if you operate on a patient with pre-existing uncontrolled hyperthyroidism and give them norepi and epi in the OR. And I think infections are probably a big trigger. I don't know that, but I would through analogic reasoning. So I completely agree with you. Nothing in the illness script of thyrotoxicosis and thyroid storm involves, in my mind, an exudative pharyngitis. So I think that has to be treated in parallel. And the way that you can potentially merge those two things is to say that the pharyngitis triggered the thyroidism. So that's going to be really, really important. AMK, enlighten us, please.
Okay, so the throat swab came back with 4+ Streptococcus dysgalactiae and did really well with the ceftriaxone as well as treating the thyrotoxicosis. Kind of how I put this case together was kind of how you did, Robbie. So that she had baseline hyperthyroidism that had presented to PCP a month ago and was starting to have symptoms, and then developed this bacterial pharyngitis and decompensated further. So, you know, I calculated the thyroid storm calculator and it was 50, but that was when she had a fever, which it was hard to say, like, is this fever due to thyrotoxicosis or this infection? But like when she was afebrile, the heart rate came down appropriately. And when you calculated it, it was not indicative of thyroid storm. So kind of what we decided with the endocrine team is if decompensation, we would like start steroids and everything. But since she did so well just on the methimazole and propranolol, we did not end up doing that and just treated it as thyrotoxicosis with a concomitant group A strep pharyngitis. And thankfully did really well overall with it. So I just thought that was an interesting presentation. I thought one of the big clues here was the absolute neutrophil count a month prior. And I'm sorry, I forgot to mention this out loud, was 600. And then it was 7,000 when she came in. And, you know, a month prior, she was even off all thyroid medications and everything like that. So even though she didn't have leukocytosis, she had a big jump in the neutrophil count, which was a clue of a possible bacterial etiology. Oh, and did with a protein gap, did have like a hepatitis C and everything. It was negative as well. So probably just due to the acute bacterial infection.
You know, Emery, I know we're going to learn from Tiago, and I'll pass the mic to Reza to reflect before we do that. But I think your attention to detail in this case is a game changer. Because it's very easy to say you have a patient with Graves' disease who comes in who is a tremor and has tachycardia, hyperthyroidism. But I think the fact that you picked up the relative change in the white count, very astute observation, and one that only can come with a lot of practice. And the fact that you picked up that the pharyngitis, which you could easily attribute to endocrine manifestations in the throat, like we talked about that earlier on, that you noticed that it was actually exudative, you looked closely in the throat and you cultured it. I think who knows what the outcome is of treating hyperthyroidism without treating the underlying trigger of it. So really kudos to you for paying so much attention to detail. It's so clear here, and picking up relative neutrophilia and a relatively unusual pharyngeal exam. And those I think were key for this patient. And so thank you for putting this case together last minute with no notice whatsoever, and for sharing how important it is sometimes to step back and be like, I know what's happening, but what's the trigger? Let's point out the breaks in the illness script. And the breaks are, why did the white count skyrocket, relatively speaking, and why is there pus in the pharynx?
Yeah,
really.
Thank you. I echo that. I want to pass the mic to Tiago to just hear his reflections. And I just want to also say, AMK, like Robbie and I just discussed the case, and I just wasn't feeling too great about the performance of that case. And I think this skill of like discussing live is just like any other skill. You can't get too discouraged, and know that there are going to be cases where you have like an amazing time and that you just ride this like epic roller coaster. And sometimes, you'll take the shot, you'll miss the shot. But I think the important thing is to keep putting yourself in a position to practice. Not expecting anyone to be perfect. And it's through practice here that you're better for your patient, tomorrow. So I just want to thank you for presenting this. And Robbie, it seems like I'm going to be able to enjoy the Lake Geneva, where I'm going to go into Lake Geneva with Liz. We're going to have some cocktails and some appetizers. And I owe that to AMK, but I want to give the mic to Tiago because I just spoke too much.
Yeah, so it's a difficult position you put me, because you discussed the case very well. So I have nothing much to add. And I'm using my cell phone today, so it's not easy to follow the chat. So I didn't participate as I would like. But what can I say? So if you have a patient with Graves' disease and this patient comes to the ER, think about thyroid storm and then use the Birch-Wartofsky scale. So, this is fluid. I think this is an important point that Anne-Marie brought, because, myocardial infarction, you have a definition. The definition is clear. You have necrosis, you know what's going on, and you have you have markers that you trust. But what is thyroid storm? You have the Birch-Wartofsky score. Then if it's less than 25, it's unlikely. It's more than 45, it's very likely. And if it's from 25 to 45, it's like, what's going on? Because, there is no, so there is the normal, that you have thyrotoxicosis, and you can have like an extreme, which is thyroid storm that happened, this case triggered by an infection. But, when do you call it thyroid storm? That's the point. So that's the reason we don't know very well what's going on, but we know that there is a possibility of it being thyroid storm. But when do you call it thyroid storm? That's very subjective. There is no clear cutoff, and the mortality is very high, so you need to treat. And regarding treatment, it's the second time I hear Reza's story, and it's not common. Most patients, they will go very well with beta blockers. And just one important point, so Lugol or iodine, it can be used, so the package, you have to do 4 things, right? And iodine is in the package, but just after methimazole, because iodine can impair thyroid function, but it can cause both Chekhov effect, meaning decreasing the thyroid function, or Jod-Basedow effect, which is increasing thyroid function. And here you don't want Jod-Basedow effect. So how can you guarantee it will not happen? You block the gland. How can you block the gland? Propyltracer or methimazole. So it's very important to iodine only after at least 1 hour that you initiated methimazole or propyltracer. I think this is an important point, and you don't want to miss it. And I think that's it. I talked a lot.
Everyone keeps saying they talk a lot, but the only person who's actually talking a lot is me, who's interjecting with everybody. Thank you all for the wisdom you're sharing. I say this because Laura told me that I talk a lot yesterday, and then she felt so guilty that she said that, and felt so bad that she said that, she texted me to apologize. I just want to publicly say and acknowledge that I know that I ramble on and on and on, and I have no shame about it. And Laura, as you pointed out yesterday yourself, you also have the bug of narrating your thoughts as freely as possible. And with that, I hopefully made you even more nervous than you might have been already to take us home. Please do. The organization of the whiteboard looks awesome.
I didn't mean that you speak too much, just a lot.
See?
And
Meanwhile,
what I meant, it was like, if we ever start a conversation, it's probably gonna last like 75 years. So
I know, right? We're already doing it right now. We started already.
Yeah. Okay. So I'm gonna do the teaching points today. I just want to say it was amazing, and I just love learning from all of you and from Tiago. Tiago, if I say anything wrong, please correct me. I did my best. So We have a patient with pharyngitis, and the causes could be infections. So we thought about group A strep and sexually transmitted infections. Also autoimmune, drug-induced, and malignancy. We also have to check if it's suppurative, if there are local complications. And Robbie told us that the most common presentation of pharyngitis doesn't include systemic features. So if there are, it probably leads us to virus or group A strep infection. And so the patient had this Graves' disease diagnosed, and so it is a hyperthyroidism, with autoimmune cause, and it represents 80% of the cases. And to diagnose it, we should include symptoms and low TSH and high T3 and T4. And Reza told us that medication could cause bone marrow suppression, so we should be aware of that. And the treatment is radioablation. For the inflammation that we thought the patient had, Robbie told us about the compensatory sympathomimetic response, that it is never more important or like higher than the insult itself, but the patient had sympathetic toxicity. So we could see that because of the presence of tremor and spontaneous hypokalemia. And lastly, we talked about thyroid storm, and it is an endocrine emergency, which almost universally presents with fever and organ damage. And there is a risk of quick cardiopulmonary decompensation, and the management is supportive with cooling and fluids, alongside with measures to taken to reduce thyroid hormone synthesis, hormone release, and inhibition of the peripheral effects of excessive thyroid hormones. So yeah, that's what I had to say. And I just want to remind everyone that tomorrow we have the special VMR for the IMGs that are applying this year. And honestly, if you're not applying this year, you should come too, because it's going to be amazing. And yeah, I'll see you tomorrow.
Thank you, Laura. I want to reinforce that tomorrow is a special day. We have folks from Jacobi Medical Center in New York City. They're going to be coming and telling us about their program. If you're interested just in general, as somebody who's interested in programs, they're also going to be bringing a doozy of a case, especially prepared for VMR. So if you're interested in clinical reasoning, you should join us. But then at the end, they're going to have a special conversation about their international medical graduates and input about IMGs. So this is a session for anyone who's interested in clinical reasoning, anyone who's interested in residency programs in the United States, but especially so if you're an international medical graduate. We hope to see you there, and have a wonderful day.
Hey, Robbie, can I ask a question to you guys and Tiago about beta blockers?
Absolutely.
I know it's always, propranolol, but what if your institution doesn't have like IV propranolol? And what is your go-to? Is it metoprolol or labetalol? I was just curious.
I have no idea. I've never treated thyroid storm, so I'll ask Tiago if he has any thoughts.
I would use a tenolol, propranolol. I've used both, but if I didn't have any one of these, I would reach. I don't know.
Is it more just going for like a non-selective? I mean, I don't even think, we have, I think we have esmolol and labetalol and metoprolol. Those are our IV formulations. And honestly, I have not had that situation either. So, it's all just, what if. But if their blood pressure is, on the lower end, I would go metoprolol. But if it's elevated, then I would go with labetalol. But I just was curious to see what you all would do. Maybe a thread, Tiago. Let's do a thread on Twitter.
Let's.
Oh, I was just going to say, it's a marker of an emergency room doctor who is constantly thinking, what if, and preparing for all situations. Kudos to you for exhibiting that here. Yeah, we should totally talk about this and
Travis, Up to Date has an answer to your question if you want to hear it.
Oh, yes, please.
Up to Date recommends propranolol first, but the Japanese guidelines recommend esmolol. So it sounds like that should be your go-to as an IV if you've got it.
Perfect.
And then certain considerations, like if a patient has active asthma or bronchospasm, you might consider a cardioselective like metoprolol or atenolol. So it sounds like esmolol probably your next choice if you don't have propranolol. And I think
Perfect.
we lost Robbie.
We have that one. So thank you. And Laura, thanks for filling in. I didn't hear the whole case, but I heard the wrap up and it was awesome. So
Great. Thank you, Rebecca.
bye, everybody.